Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we have an education episode that I feel like everyone will give 2 thumbs up.
Unless they're injured.
And then maybe 1 thumb up, 1 thumb down. Yeah, so if you haven't noticed, we'll be talking about the thumb.
So this is a CEU episode, so if you're listening to it as it comes out, it is a free Category A CEU. If you're listening to it as it is one of our older episodes, you can purchase it from, thank you so much to Clinically Pressed and Athletic Training Chat. Show notes down in the show notes below is where all the details are, how to get your certificate. It will automatically be generated if you do your quiz and course evaluation. So just check those out. And we also have other CEUs. So if you are interested in staying on top of those, it is a reporting year. And please share to your friends who also need CEUs.
Yes, definitely.
So what are we talking about today, Randy?
Yeah, so we're going to talk about the relevant anatomy of the thumb because why not? Because it's rad. Thumbs up, get it rad. All right, moving on. We'll discuss the evaluation and treatment of various thumb pathologies. And then we'll also kind of discuss some of those return to play considerations after thumb pathology. It's interesting, like some of that return to play is like, it's really different based on sport. And like, you know, like in sports like football, you can kind of get away with a couple things because you can kind of protect it a little bit better than say if you like play a hand kind of dominant sport.
Absolutely. And I mean, it also depends on the position though.
Yeah, it depends on the position for sure. And if you're quarterback, you're not going to see your quarterback with a club. It's going to be a little weird.
Yeah. Maybe a splint. But
maybe a splint, yes, but not a club.
Depending on what it is. So let's get started with the anatomy.
Yeah, so when we talk about thumb injuries, right, it's really important to understand just the ligamentous anatomy of the thumb. That's really kind of where we tend to see a lot of these injuries.
I mean, it's such a mobile joint.
Yeah, for sure. And I definitely have seen it with my volleyball athletes.
Oh, definitely,
see it a lot with people just getting crushed when they're going up for a block.
Mm-hmm.
So our static stabilizers of the thumb include the UCL, RCL, the volar plate, and then the dorsal capsule, right? But in particular, we're going to really talk about and focus on the UCL and RCL.
Mm-hmm.
So both of these ligaments do have 2 bundles because, you know, why not? Can't make it easy. You just have 1 bundle. All right, so the UCL has 2 bundles. One is referred to as the proper, and this provides that valgus stability in flexion. In particular, the maximum stability is in about 30 degrees of flexion. Right,
okay.
So keep that in mind as you think about how do I evaluate this. And then it has what's referred to as an accessory section or bundle that provides the valgus stability when you're in extension. Right, some of this,
any specific angle or just in general?
No, full MCP extension. Okay. And it really, again, just really goes on just how the anatomy is and just how they kind of course around the thumb and the directions that they run, that they really find their roles of being, at what degrees do they have stability.
Mm-hmm.
For the RCL, it's slightly similar as the UCL. The RCL is the primary radial stabilizer for the thumb. What's really important about the difference between kind of the RCL, UCL kind of area is the UCL has a lot more muscular protection. The muscular attachments around the kind of the ulnar side of the thumb are a lot more compared to the RCL. There's really not a lot of attachments there, so it's really hard to kind of protect that joint dynamically.
So what does protect it?
So that RCL, again, has 2 bundles. So you have, again, kind of the same names. You have the proper bundle, which is your kind of main stabilizer, again, in flexion. And then your accessory, which is the main stabilizer in extension. So when you kind of think about evaluation, it's kind of like your knee, right? You do your valgus and varus at 0, valgus varus at 30. Right? So same thing for the thumb. Right? Mm-hmm. You're just trying to see what bundles are kind of damaged when you do the evaluation.
That's a good point because I feel like most people just do it in kind of one
and
plane.
When you know, it's funny you say that because when I was reading this, I was kind of thinking, I was like, oh, I should do that. Right? Like, because I fall into that too, where I just,
and especially like
problem.
Finger evals, you know, you check for fracture, check for stability, and you're like, okay, like,
Go get him, Chief.
And usually it's like a side lane eval. It's really quick.
Yeah.
You know.
Yeah, for sure. So yeah, no, that was kind of an important thing that I'm like, oh yeah, that kind of brings up a good point. And I believe, you know, in our kind of hand injury when we talked about fingers, it was the same thing, right? You do extension and then you also want to go down into some flexion to also test it that way as well. We will talk about some like bony injuries, so kind of getting an idea of the bony anatomy. I think most people understand the phalanges, the proximal distal, right? So we don't need to necessarily go that far into it. So I think one of the more kind of noteworthy aspects of the bony anatomy for the thumb is that articulation between the first metacarpal and the trapezium, because this is what's actually creating that kind of saddle joint. And like you said, that's what gives us our thumb the mobility, because it is a pretty mobile joint.
It's so mobile, right?
Some people have argued this is what makes us human, opposable thumbs.
Actually, I was just about to say that.
Yeah. Right, we can open doors. Right, so I think that's kind of one aspect that's very important. I mean, obviously we know the metacarpal and the first MCP and stuff like that, but I think very noteworthy is really considering that saddle joint. So now we kind of have that baseline of just simple anatomy kind of going into talking about some of these pathologies. And really when you think of the thumb, there could be a number of issues that can pop up. Right, but in particular, we're going to talk about kind of like more kind of bony pathologies and then the collateral ligament damage. So when we talk about bony, right, we have the dislocation of the first CMC. That's not Christian McCaffrey for all the Niner fans out there. It is the carpometacarpal joint. Right, so this is actually that connection between the first metacarpal, the trapezium. And this tends to be rare. You really don't see a lot of dislocations here. You're going to see more maybe a subluxation or a sprain being a little bit more common. Mm-hmm. And really the mechanism is just an axial load with a flexed thumb, which again, you can kind of see why it's kind of difficult. It's really hard to kind of land like that.
Well, I had a quarterback who landed like that. And he literally no one was around him. He just stepped back. We were playing on a grass field and he stepped back and fell backwards and fell like with a flexed thumb and literally just came off and he was like, my thumb's broken. And I was like, no, it's not. And I just popped it back in. And then I was like, and then he was like, oh, okay, cool. And he went to move it and it just came back out. And I was like, oh, that's weird. So I put it back and I was like, let's test that. I think I was like 6 months certified.
Yeah.
And then boom, pops out again. And I was like, no, you're done. We're sending this.
And then what did the doctor say?
He ended up having surgery. He tore everything in his thumb. Just from falling. He said he hadn't seen one of those in 10 years. And the last time he saw it was because of a car accident.
That's great. And you saw it at 6 months certified.
Yeah. There you go.
Welcome.
Yeah. Welcome.
One thing to kind of consider with these injuries is it may be associated with a Bennett's fracture, which is a fracture to that proximal end of the first metacarpal, in particular in the actual joint as well. So that's something to kind of keep in mind and be careful of. When they kind of present to you, right, they may present with kind of an adducted thumb, and basically more than likely the thumb will be displaced dorsally.
You know how I remember a Bennett fracture?
How?
Because my program director was named Dr. Bennett. And so the way he taught us, because Bennett's number one.
Yeah.
Thumb side is number one. So it's the fracture associated with the first.
Did he make sure to emphasize that Bennett was number one?
Yes. Oh, yeah.
That's pretty funny.
I still remember it to this day.
I mean, who could forget that? All right. So transitioning to another dislocation pathology to kind of just keep in mind is that first MCP joint dislocation, so the metacarpal phalangeal joint. And again, this tends to be in kind of that dorsal direction and can result from hyperextension of the thumb. How they kind of categorize it is you can have a complex dislocation, and this is something that's like you can't reduce this like just normally, right? This is going to require surgery to actually reduce. And how you can kind of tell the difference is it'll present with like some puckering of the skin right at the metacarpal head. So it's almost like it probably looks like it'll kind of get sucked under. And that'll kind of give you an indication, hey, I probably shouldn't try to reduce this on the field.
They won't let you.
Yeah, they probably won't want you to. And then a simple category is just something that it doesn't present that way, and you could reduce it on the field. So those are our dislocations. We'll kind of talk about a little bit about the management in the next section, so don't worry. I didn't forget about that. Going into our kind of ligament pathologies, you have your UCL sprain, and this is kind of the most common injury in the thumb. And some have found the most common injury in the hand as well.
I could see that.
Yeah, I feel like it does happen quite a bit. And really, it's anything that just causes that excessive valgus force in the thumb, right? So this is what's commonly referred to as like skier's thumb, right? Because when you fall skiing, right, your thumb hits the ground and boom.
That would cause a skier's thumb.
Yes. All right, so evaluation's pretty simple, right? You're going to have pain over your UCL, right? And there might be some laxity with valgus stress tests.
Mm-hmm.
All right, the one thing to keep in mind when evaluating these is high levels of laxity. So when that bad boy really opens up, right, that could indicate a rupture. And I think like technically numbers are like, oh, if it has valgus of over 30 degrees, right, that's like complete rupture. And like, I don't know how many people are pulling out their goni when they're doing stress tests, but basically.
Just make sure that you're doing it at different various levels.
That's true, yes.
Various angles of flexion.
But one thing that I actually did learn from the reading, and something to keep in mind, is another indication of a UCL rupture in the thumb is the presence of a Stenner lesion. And what this is a palpable mass right over that kind of ulnar side of the thumb, right over where the UCL would be. And basically this occurs when the UCL basically an avulsion fracture of the proximal phalanx.
A Stenner lesion.
Yeah. So you'll actually feel like a more prominent bump here, and you're like, oh, that's weird.
How many of us are feeling our thumbs right now? Because I am.
I've literally been tapping it this whole time. So shifting from ulnar to going to the rad side. This is the rad side of the episode. It's a lot more rare than the UCL. And
yeah, have you ever seen one of these?
I was going to say, when I started thinking about it, I was like, I guess I don't have a lot of athletes complain of RCL pain.
I have had people complain of them, but I haven't had any laxity that I can remember off the top of my head.
Dude, I actually had, sorry, not to go back to the ulnar side. It's not as rad. Literally like a few weeks ago, one of our incoming basketball guys came in. He was like, hey, can you tape my thumb? I was like, yeah, let me take a look. And I did a valgus. I'm like, oh boy.
And it moved a lot?
Oh, it was basically floating. I was like, no. That needs more than tape, buddy.
Yeah. You're like, sorry, tape won't fix this one.
No. But yeah, so RCL, a lot more rare. And again, it just happens with the reverse, right? It just a varus force overcomes the RCL. But interestingly, it can happen with torsional force too. So kind of that kind of torsion on the thumb.
Okay, you know what was funny is actually I was trying to think of the people who I've had like an RCL pain with are usually like an axial load jam or like something like that, or like a torsional. So that makes sense that would cause that. Because I can't really think of anything that would. I can't think of anyone who's complained to me about a varus force on their thumb.
I was gonna say, I feel like that's really hard to do. Like just kind of think of the anatomy of like getting it caught enough to do that. So yeah, like an axial load I could see, and it gives that way. Mm-hmm. I could see that, especially because there's not a lot of dynamic stability on that side too.
Right.
Yeah.
Because it doesn't have those muscular
attachments. Stabilizers. Evaluation again, same thing as UCL, right? Instead of valgus, you do varus.
Damn it.
Just gonna say that. All right, so now the bread and butter, what probably everyone's here for, is the management.
What do we do?
We got to manage this thing. Yeah. You got to do it. Mm-hmm. All right, so for your dislocations, and like I really don't want to talk about the reduction techniques, right? I think this is a better thing to bring up to your team physicians. Again, NATA put out a great position statement on joint reductions. So I think that's a great conversation to have with your team physicians on, hey, how exactly do we do this? Should we be doing this? Should you be doing this?
Did we do a position statement on, did we do that episode?
I think we did an interview episode on it.
With Nicolette, we did a how to talk to your team physician about reducing dislocations.
Yes. Yeah.
So check out that episode. I don't remember what number it is, but I'll try to link it.
It's an early one, actually. Like, I feel like it kind of goes. It was
a while ago.
Yeah, it was a while ago. Going back in the archives a little bit.
Mm-hmm. MVP Nicolette.
MVP. But in general, right? If the going kind of more long term kind of follow up with these, if they're stable after reduction, right, it can be treated conservatively. So it could be casted or splinted. For about 4 to 6 weeks was kind of consistent between the two dislocations we talked about. Mm-hmm. If surgery is necessary, because it's just, even with reduction, it's just not stable, like a certain case study we just heard.
So he was, actually trying to remember, it was our last game. And then I went into basketball season. He was still in a cast through at least part of basketball season. He wasn't a basketball athlete. A lot of these kids, like, they played multiple sports.
Yeah.
I don't think he was a basketball athlete, so I kind of lost contact with that. But I remember seeing him in this freaking giant cast because he had pins in it. And so then the pins had to be casted too. And he's like this high school kid, so it was the biggest cast I had seen at the time.
Yeah, so obviously that timetable after surgery can really increase how long you're immobilized for and how long before you can do things.
I actually don't even know. I don't even remember his name. I can't even picture him, actually. I can picture his thumb.
I mean, you were there for, it was an impactful time, but I feel like it was like a fairly relatively short time.
I only knew him for season, I guess.
Yeah. And you weren't necessarily there every day, right? Like, it was only a couple times a week. Mm-hmm. Yeah. So that is hard to try and get everyone down. Kind of going towards the sprains, something, again, a little bit more that we have a little more control of and kind of management. If you have a high-grade UCL sprain, right, really it's recommended that that's going to be managed surgically. Right?
Especially like thumb, like any opposition or like...
Yeah, it's really important.
Right.
To how we function as humans.
Or if you want to give someone a thumbs up again.
Yeah. Because,
a stable thumbs up.
Yeah, exactly. You don't want thumb slipping out every time you come up. You're looking at basically after surgery, they're going to be in a cast for about 6 weeks. They'll transition to a splint for an extra, for a little bit longer. Really, they could start kind of strengthening outside the splint at around week 8 post-op. But you're not looking at unrestricted activity away from the splint until around 12 to 16 weeks. Now, there is some, like, depending on the sport and how they're doing, right? You might be able to get away if it's protected in the splint. For certain sports, they might be able to get away with it from what I was reading. But again, I think that's a better conversation with the surgeon and your team physician of how plausible is it that this person can play at this time frame.
I know something that we've done and Juan talks about it in our football episode, is a soft cast.
Yeah.
And he's introduced me to those, the soft cast. And you could just take, like, it's a soft cast material and you just make it to them and then you just cut it off. And then you can re-put it on with, like, Coflex.
Yeah. Ooh. Ooh.
Mm-hmm. And it's not, like, as hard as a traditional cast, but, like, it's like a good transitional, because I've used like orthoplast.
I was just about to ask, what's the difference? Like, what have you noticed different?
Orthoplast is so stiff, like
okay,
you're not moving that. Like it's very hard. Whereas a soft cast, it has some give to it.
Okay.
So if they need to like catch, for example, you can like pad it.
Oh, okay.
Like I've used it like on a tight end.
Okay.
That would be a lot better than like an orthoplast I would use probably for like an O-line or like D-line or someone that's like really like, I really don't want that thing to move.
Yeah.
Whereas like someone who has to have some give, I'd probably use more of a soft cast. And for depending on like when it is in the recovery.
Yeah. Yeah, for sure. Right. And I think that's a good point. Like I think especially working football, you've seen a lot of the ways that you could protect these, especially thumb injuries, and get someone to play. Whereas it's really hard in some of the sports that I work because they are so hand dominant that it's really hard to like, I can't make it too bulky.
Right.
So this tends to kind of limit me more than I think you guys have a lot more play on. Okay.
We have, yeah.
What can we do?
Right.
Right.
Basketball, 1-inch elastic on. Volleyball, 1-inch elastic.
Yes. That's basically what, I mean, I have for volleyball, I have done the orthoplast, but I just made it a little bit smaller so they actually have some thumb motion, but also protecting that MCP. And that worked a lot. That worked pretty well. Right. Again, like she's not really like a setter, so I'm not really worried about that. I'm more worried about, hey, let's protect while you're blocking and hitting. Right. So that actually that was helpful.
Something that Juan's also introduced me to that just specifically for that is he does just like a 1-inch spica of the orthoplast on the thumb, and that's it. And then he tapes it on.
Holy smokes, I like that.
Yeah.
I would have to see that.
Yeah.
I'm down. Count me in.
It's really small. It's just the like,
I feel like
covers
that'd be
the MCP
a lot
joint.
more comfortable. Mm-hmm. That's interesting. I like that.
You just have to stretch it out a little bit so it's not too
too constricting.
Because once it's hard, like it's like a ring.
Yeah. That's what I pictured.
Right.
So as we've kind of alluded to, partial tears can be managed conservatively. And really in general, right, we're really kind of gearing for immobilization for 4 to 6 weeks, right? So we want to put them in a splint during their recovery around 4 to 6 weeks. Really grip strength and pinching shouldn't begin until they either get full range of motion or at about 6 weeks time to let that heal. Returning to sport usually depends on the severity and the nature of the sport, right? So again, minor injuries, you could see a return 2 to 4 weeks with a splint. I'm sure it could probably be a little bit sooner if it's very mild and if you could protect it very well. And then contact sports, again, right, it might need a little bit longer. They might need to actually be protected for like 6 weeks, right, to prevent it from being re-injured while they're out there.
I feel like, especially football, usually if something needs to be protected, it's like you're being protected for the rest of the season.
Well, I mean, okay, so when you think about that number, like 6 weeks, I mean, shoot, your guys' season, at least for college, is basically 10.
Yeah.
Like, that's pretty much the year.
Right.
So you might as well just keep it going, because then you know what happens is the day they take it off,
they're going to re-injure it, and then
they come back right.
And at that point, they're used to it.
Yeah. And then
although sometimes they are dying to get out of whatever splint.
For sure. But then
wrap,
but
tape.
then when they are, and then again it's re-injured, then you're kicking yourself like, oh, we should have just kept it on.
Right.
So that's UCL. Right now we're going back to the RAD. We're finishing on RAD. There's not a lot of clear guidance on how to manage a complete rupture of RCL. Right,
dude, I can't, like, if you manage to rupture your RCL,
there's gotta be a lot of damage.
Like, what else? Yeah, what else is damaged?
Some have advocated for, hey, maybe it should be similar to the UCL. Right? You should probably need surgery. I know if I have someone who's full ruptured, I'm referring that bad boy just in case. Like, yeah, let's.
Right.
Is this surgery or not? But the protocol for like that whole management after surgery is similar to UCL. Right, so it's not really, it doesn't deviate that much. For partial tears, again, it's very similar, right? You're going to mobilize 4 to 6 weeks, and then you can start transitioning to a removable splint, one that they can kind of take on and off. Probably mostly for games that they'll have it on for like an additional 2 weeks.
Nice.
Yeah.
Some bonus rehab. Something that we've been doing lately is we took a tennis ball and we cut a slit in it so it looks like Pac-Man, and they have to pick up marbles.
Oh my gosh, I saw you guys doing that, or I saw a video or something, and I'm like, that's genius.
I saw it on Instagram.
I want to do that now, because
you know what's actually really great? Look up hand, like occupational therapists or like hand therapists, and they are like, they have I thought I've exhausted my brain of rehab exercises for the hand, but then you go on Instagram, there are so many that you can do, especially for some people who like specialize in this area.
I was gonna say, like, OTs, man. That's their bread and butter.
Right. So that, and it makes it fun.
It's something, I was gonna say, it's something different than
Pac-Man.
like, because you could do like the marble pickup by hand, but then it's like, what are we doing? Like, I feel like that's not stressing enough for like an athlete.
So what I learned is if the bigger you make the slit in the tennis ball, the easier it is to squeeze.
Minimal.
So if you make a small slit, obviously it's gonna be harder. So I think I'm gonna make another one with a smaller, because I like started with a small and then I was like, oh, the mouth isn't big enough, and then like bigger. Okay, you know, like that measure twice, cut once. Yeah, no.
Well, okay, but also like tennis balls, like dime a dozen.
Exactly.
Right?
Exactly.
Yeah, you mess that up.
Or just go like right outside of the tennis courts after they're done.
Oh, there's plenty of like dead balls.
Or yeah, I was just about to say the ones that are dead.
Yeah, they're gonna get rid of them anyways.
Right.
Ooh, what I use, sorry, not to go on a tangent, but lacrosse balls. If you have a lacrosse team or any kind of lacrosse that practices on your campus, just go out there after they're done. You'll find a good lacrosse ball somewhere.
Or you could just ask them.
But like if you don't know them,
you should probably ask them.
Just saying. Sometimes you'll find them in the bushes and you're like, yes.
You're funny.
Yes.
What is your action item for this?
Thumbs cool, man.
You mean like thumbs up?
Thumbs up.
Thumbs up cool?
I think from reading this, I think that the management, I feel like a lot of people don't think of that immobilization time with hand injuries, wrist injuries, and like thumb injuries. Like I feel like you look at it and you're like, oh yeah, it's sprained, we can tape that. But then I feel like we're like, I know for me, like it was really hard for me to think of like, oh yeah, you should be splinting this when you're not doing things.
You know, I have to say, I am a changed woman from wrist braces. I love them. They are my favorite piece of equipment.
Yeah, and I think that's one thing. Like this year, like I never had like the actual thumb splints, but this past year I ordered the braces for it, and that has been a game changer.
They make such a difference. Like literally, the way I get buy-in is I give them the wrist brace. If that like a wrist sprain, we could talk about thumb sprains too, but like just specifically, I get more wrist sprains. So I give them the wrist brace and I say, just hear me out for 24 hours. Put it on for 24 hours. If it works, we can keep it. If it doesn't, then what's 24 hours, right? I have not had anyone who hasn't gotten at least a little bit better in 24 hours. And most of the time, they're like, oh yeah, I'll keep this on.
Good.
Because it helps.
Well, because you're probably going to need to keep it on for 4 to 6 weeks, so get comfy. No,
I usually don't keep it on that long, but
yeah. So that's what I would
I make
say.
them, usually it's about a week.
Okay.
At tops.
Yeah.
Maybe like 4-5 days.
Yeah.
Average.
Yeah. So I would say, like, don't forget that time of actually protecting the tissue. Like, I know it seems like it's kind of bulky and, oh, it's not cool. And, like, you know, the athletes will complain. Some of them might. Maybe not all of them.
Tell them to, like, wear a hoodie, like, with the sleeves, like, over their hands.
Yeah. That's what I would say, is don't forget that time to actually protect the healing ligaments. And then, think of some cool creative ways to do rehab, because it feels like you're so limited on hand rehab. And I feel like you just kind of end up doing the same thing. So yeah, like the Pac-Man thing, like that's really cool.
You can only stretch putty so many different.
You can only play with the putty and the webbing for so much.
Or the rice bucket.
Or the sand.
Or the sand. Oh, I haven't done sand.
Yeah. You can only do that so many times before you're like, okay.
So if you're interested in the references that Randy used to read up on this episode, you can head to our website, which is also in the show notes, where you will also find a bunch of fun goodies and stuff like MedBridge, who we work with to bring you CEUs, like promo codes for them. We have every episode that we do is education like this, CEUs, or we do story episodes where we bring stories from real life athletic trainers. We are actually doing a story episode next week, and because it's the end of May, it will be our last episode of season 5.
Wow.
That's crazy.
Damn.
So we will be back in August as we run August through May. We take June and July. Just to prep for next season. But we will still be active on our Instagram. So keep an eye out. And we will be at NATA. So if you're going to NATA, please let us know. We'd love to meet you.
give us a thumbs up. We'll know what that means now. If I remember now.
Seriously.
If I remember. Someone's going to be like doing thumbs up at me and I'm going to be like, yeah.
As long as you don't give us a thumbs down.
Yeah, that would sting a little.
In person, just like walk up like.
Yeah, that one would actually probably sting a little. Yeah, maybe don't do that, please.
All right. Do you have anything else?
Nope. Thank you for helping us showcase athlete training behind the tape. Bye.